Hi, Chris. Did you want to validate? Can you hear okay?
Yes. Hi, Bruce. We hear you well. You see you well. Thank you so much.
Hello, everyone. It's June 18th. My name is Tariq Esharevic, and I welcome you to this regular COVID-19 press briefing from WHO headquarters here in Geneva, Switzerland. We have a number of speakers today that I will introduce shortly. I will also remind you that this press briefing has simultaneous interpretation in 6 UN languages, plus Portuguese and plus Hindi. Journalists who are online will click on icon raise the hand and can ask questions in 6 UN languages and Portuguese today. We have with us our usual speakers, Dr. Tedros, WHO Director General, Dr. Maria Van Kerkhove, our technical lead for COVID-19, Dr. Mike Ryan, Executive Director of Health Emergency Program, Dr. Soumya Swaminathan, WHO Chief Scientist, Dr. Mariangela Shimao, Assistant Director General, Access to Medicines and Health Products. Online, we have with us Dr. Bruce Aylward, Senior Advisor to the Director General and the lead of ACT Accelerator, Dr. Kate O'Brien, Director of Immunization, Vaccines and Biologicals. We also have today with us Dr. Deborah Kestel, who is our Director for Mental Health and Substance Abuse. So with this, I will give the floor to Dr. Tedros for his opening remarks. Dr. Tedros.
Thank you, Tariq. Good morning, good afternoon, and good evening. Tomorrow, we expect the government of Guinea to announce the end of its Ebola outbreak. And I would like to offer my congratulations to Guinea and the health workers who helped to contain the outbreak at very high personal risk. Thank you also to our partners who provided financial and technical support. As you know, Guinea was one of 3 countries that was affected by the devastating West African Ebola outbreak in 2014 and 2015. Thanks to the lessons learned from that outbreak and new tools, including vaccines, Guinea managed to contain the outbreak in just 4 months and prevent it from spreading beyond its borders. Nearly 11,000 people were vaccinated against Ebola. But our work is far from over. We must continue to support survivors and monitor their health without creating stigma. Our teams are also finalizing a 90-day post-epidemic resilience plan to support local health authorities, health workers, and communities. This success shows how an outbreak can be brought under control with the combination of community engagement, effective public health measures, and the equitable use of vaccines. COVID-19 is a different disease that spreads more easily than Ebola, but the approach is the same. And yet, even after 18 months, the ineffective use of public health and social measures, increased social mixing and vaccine inequity continue to give COVID-19 an opportunity to mutate, spread, and kill. The global failure to share vaccines equitably is fueling a 2-track pandemic that's now taking its toll on some of the world's poorest and most vulnerable people. Every region has countries that are now facing a steep increase in cases and deaths. Many countries in Latin America have rapidly increasing epidemics, and others have plateaued at high level. In Africa, cases have increased by 52% just in the past week, and deaths have increased by 32%. And we expect things to only get worse. Less than 1% of Africa's population has been vaccinated. Vaccines donated next year will be far too late for those who are dying today, or being infected today, or at risk today. Our global targets are to vaccinate at least 10% of the population of every country by September, at least 40% by the end of the year, and 70% by the middle of next year. These are the critical milestones we must reach together to end the pandemic. more than half of all high and upper middle income countries and economies have now administered enough doses to fully vaccinate at least 20% of their populations. Just 3 out of 79 low and middle income countries have reached the same level. We very much appreciate the vaccine donations announced by the G7 and others. And we thank those countries, including the United States, that have committed to sharing doses in June and July. We urge others to follow suit. We need vaccines to be donated now to save lives. WHO will continue to support countries to apply public health and social measures to keep people safe. And we continue to support countries to ready their systems and plans to roll out vaccines once they get them. But we do not control the global supply of vaccines. The countries and companies that do must play their part to produce more and share more to achieve WHO's global targets. We continue to explore every avenue of increasing production of vaccines, especially in Africa, and we will have more to say about that on Monday. And even as we continue to respond to the COVID-19 pandemic, our regular work continues across the spectrum of health issues. This week alone, we opened a new country office in Kuwait, published a new implementation guide on suicide prevention, and yesterday we launched the Global Evidence Review on Health and Migration. Refugees and migrants are among the most vulnerable people in our world and suffer from a range of physical and mental health problems. And yet, data on the health of refugees and migrants is scarce and needs to be improved to support the best policy decisions. WHO's new Global Evidence Review on Health and Migration will set evidence-informed norms and standards to address data gaps and support global guidance and strategies on improving the health of refugees and migrants. It's another way WHO is working to fulfill its mission to promote health, keep the world safe, and serve the vulnerable. Tariq, back to you.
Thank you, Dr. Tedros, for these opening remarks. We will now open the floor to questions, and we will start with Corinne Gretler from Bloomberg. Corinne, please unmute yourself and go ahead.
Hi, thanks for taking my question. My question's for Bruce. I just wanted to ask, since we're talking about vaccine donations next year would be too late, and not many have dedicated donations June and July. So are you aware of any nations, cities, or towns that have been forced to halt vaccination rollouts, but also maybe, setting aside second doses for healthcare workers and others?
Thank you, Corinne. Dr. Aylward?
Yeah, thank you very much, Karen, because this is a crucially important point that you've raised. What I'd like to suggest is that Kate O'Brien, who we have with us for the first part of the call, may be able to join in on this point. But we have a huge number of countries, Karen, that have had to suspend their rollout of their second doses of vaccine. If I remember correctly, it's over 30 or 40 countries that could have been targeted for second doses of AstraZeneca vaccines, for example, will not be able to do that. And we are now urgently trying to work with AstraZeneca itself, as well as SII, the government of India, to restart those shipments so that we can get those doses, those second doses into those populations, because we are running to a longer interval than we would have liked in that regard. So it's quite a list of countries, particularly in sub-Saharan Africa, but also parts of Latin America, parts of the Middle East, South Asia, as well that have all been hit hard by this. Some countries have been particularly hit hard, include those that surrounded India, like Nepal, Sri Lanka, others who suffered a severe wave of disease and were very, very desperately trying to access doses. So we've had quite a substantial problem in this regard, Karen. And hence the reason the Director General emphasizing the need for access to doses. Donations are great in the short term. This is a short-term solution we are looking for in the face of a very imperfect market where in this pandemic, only countries right now that have got the financial resources or producing the products actually have access to vaccines. And that's what we're trying to change, particularly in this period, June through September. In that regard, just like to recognize again the importance of the donations that were announced and dose sharing at the G7, especially of the United States that has committed at least 80 million doses during the June-July period that will help, and we call again on others for exactly the reason that you've highlighted, Karen. Tara, Kate may want to add, and she'll be more familiar with some of the real specifics around actual countries and numbers.
Yeah, thanks for that, Bruce. You've named a number of countries that all are facing the issues that you've described. I think I really want to emphasize that countries across each of these regions are, we're looking really carefully with them at their absorptive uptake of vaccines. And many of them are at the very end of the supply that they have, and they still have not delivered second doses to their large populations for which they got first doses. So we're really facing a situation where they are in halting stage, where they just don't have more doses that are coming at this point to be able to do those second doses, and of course to then expand to the remainder of the highest risk populations that they're trying to immunize. So there are, many countries, many of which Bruce has already described, and specifically named them. We can certainly take it offline and give you further lists of countries that are facing this. Over.
Many thanks,
Tarek, one point we should highlight, Karen, that we didn't is how hard this is for countries. Remember, you've seen in the West and other countries that have high coverage, how long it took to get to high coverage. It takes a long time to train the additional manpower that you need, a long time to sensitize your populations, a long time to get the logistics, et cetera, in place to operate at scale. And so when countries with weak systems are forced to continually interrupt, reorganize, redirect their programs, they are going to have real trouble as additional doses arrive, potentially. We're making it doubly, triply difficult, much more difficult than it needs to be for these areas. Eventually, when we do get large numbers of doses, it'll be like having your hands tied behind your back, right? Both hands behind your back, because we have interrupted and staggered and slowed the rollout, which made it very difficult to mobilize populations. We hear this repeatedly from political leaders who are so keen to mobilize their populations, but so concerned that they are having to do that prematurely because the doses, the supply isn't following.
Let me actually just follow on from Bruce's second point there. We've just been looking at the pace of uptake in high-income countries, especially those that have gotten some of the highest coverage rates. And it took them over about 4 months to get to a peak vaccination rate. So, when they're really at peak pace. And those are countries that had clarity on what their supply was going to be, could mobilize demand, could communicate with their populations and their communities what the order is going to be, where you go for vaccination. We're going to have doses. One of the worst things that you can do in an immunization program is to be communicating out to the community that doses will be available, and then you cannot deliver those. That undermines confidence in the program overall. So these are really critical issues. And as Bruce said, when we're looking at some of the highest performing countries, it's taking about 3 to 4 months to even go from the beginning of a program to getting to that peak performance. It doesn't happen in a short period of time. Being able to sustain it is another issue. In each of these where they reached a peak, it was only sustained for about 4 weeks. And then that peak rate starts to go down again.
Thank you, Dr. O'Brien and Dr. Aylward. Let's move to the next question. Jamil Chade from O Estado de Sao Paulo. Jamil.
Yes, Tarek, thank you very much. Dr. Tedros, tomorrow Brazil will probably reach 500,000 deaths officially, obviously. And not only that, but we've seen in the last couple of weeks the rate going up of infection as well. What is your message today to Brazil in this such a sad milestone for the country? What is the message that you can give us? Thank you.
Thank you. Let's start with Dr. Shimão, please.
I'm going to use the opportunity to speak in Portuguese. Obrigada, Jamil, pela pergunta. E primeiro, é com muita tristeza que a OMS vê o Brasil atingir esses números, os números de óbitos e os números de pessoas que foram afetadas até esse momento, né? Você sabe que no mundo todo a gente teve já cerca de 3,8 milhões de óbitos por conta dessa doença e a OMS gostaria de se solidarizar com todas as famílias e todas as pessoas que perderam entes queridos por conta da Covid-19. É importante ressaltar que os casos nas Américas ainda, inclusive o Brasil, né, apesar de ter havido um decréscimo nas últimas semanas, eles ainda permanecem em patamares muito altos. E isso é um ponto bastante importante, acho que a gente tem ressaltado, o OMS tem ressaltado, ao tempo que congratula o Brasil pela capacidade produtiva local. Eu acredito que o Brasil tenha já conseguido vacinar tenha conseguido administrar mais de 80 milhões de doses, e a maior parte disso é por conta da produção do Instituto Butantan e da Fiocruz. Ainda há uma grande necessidade de implementar mais fortemente, de reforçar os usos das medidas que a gente chama das medidas preventivas de saúde pública, né? E que essas medidas são bastante conhecidas. Eu sei que há uma controvérsia recente no Brasil sobre o uso consistente de máscara. Essa continua sendo uma orientação da Organização Mundial da Saúde, o uso de máscara de forma consistente, onde não há possibilidade de distanciamento social, a higienização das mãos, etiqueta respiratória, ambientes ventilados e evitar aglomerações. Essas continuam sendo centrais, ao lado do aumento da cobertura vacinal, que está se fazendo gradativamente. Importante ressaltar que essa pandemia não terminou, que continua tendo pressão no sistema de saúde por conta da transmissão comunitária muito alta, e que todos os esforços que estão sendo envidados para aumentar a cobertura vacinal, têm que ser feitos em conjunto com o reforço das medidas de saúde pública. Acho que também a gente vê com muito bons olhos também as iniciativas do Ministério da Saúde para diversificar as plataformas de vacina que estão disponíveis. Eu pararia por aqui e ver se algum colega quer reforçar.
Thank you, Dr. Shimão, for this answer. I don't see anyone else who would like to add, so we will then move to the next question. We go to Reuters, and we have John Miller with us. John, please unmute yourself.
Thank you for taking my question. Obviously, yesterday we had some preliminary clinical data from CureVac, 47% for its vaccine. I'm wondering if the scientists could try to put that in perspective, given that the WHO has given some percentages that it would like to see for the vaccines, and what it would see as acceptable at this point, and how that CureVac figure might fit into that. Thanks.
Thank you, John. We will start with Dr. Swaminathan.
Thank you for that question, John. Yes, I mean, it was disappointing to see the results from CureVac that came with an efficacy of less than 50%. which is the benchmark that we had set. As you mentioned, WHO had developed through the R&D blueprint to prevent epidemics, very early on, the target product profiles for an effective and safe vaccine, setting the minimum efficacy of 50% with the lower bound of the confidence interval not going below 30%. Now, of course, it was very encouraging to see so many vaccines with much higher efficacy than the 50% benchmark. And so that's why I think it was even more disappointing to see this because we expected mRNA vaccines to perform well. But I think it's telling us important things, that in vaccine development, not every candidate is going to perform just as well, that we need to do efficacy trials to actually find out the clinical efficacy of a product, and we cannot presume just from the class of products, just because it's another mRNA vaccine, we cannot presume that all mRNAs are the same because each one has a slightly different technology. The advantage here was, of course, that the temperature conditions were very suitable. These were to be stored at regular refrigerated rather than a very cold, ultra cold storage. But it is a different kind of mRNA, unmodified platform. The dose used, selected for the trial was much lower than the dose that either Moderna or Pfizer had used. So I think we need to go much more in depth, which I'm sure the scientists at the company are doing, to look into the reasons why this could be so, because it will inform further vaccine development. And this is a normal process, as I said, of R&D of vaccines. We've been quite lucky to have so many successful ones, but it also underlines the fact that we need to keep on with development. We need to continue to support R&D of more vaccine candidates, particularly those which are more suitable for use at scale, storage conditions, single dose, mode of administration not being injectable, being either a nasal or an oral vaccine, and such other properties, easy to manufacture and scale. So I think each of these trials is a lesson for us also to learn more about the science, and there's so much more that we are learning about this virus. One of the key and important issues is a correlative protection, which would of course help further development and further testing of vaccines or vaccine combinations. And the WHO is leading on the efforts, again, through the networks convened by the R&D blueprint to come to some kind of consensus on correlates of protection. But at the moment, we do not have that global consensus, so it's very important that we continue with well-designed and well-conducted randomized trials. I don't know if anyone else wants to add to that.
Just add from the perspective of the challenge of vaccine development in the era of variants. I believe the company isolated 13 different variants in the study population, which again shows that the bar is being raised by the virus for this next generation of vaccines that we will need. So again, the message is that we need to use the vaccines we have, distribute them equitably, and ensure we continue to suppress transmission. The fact is that we've seen this in Brazil, we've seen similar issues in Paraguay and other countries recently, that even with the health system doing a great job to scale up its capacity, once you get very intense community transmission, health systems come under pressure again, regardless of the variant causing the problem. So again, I think we're seeing a shifting and changing landscape in which the emergence of variants, because of unchecked community transmission, is leading to challenges in the health system. It's leading to challenges in vaccine development and demonstrating vaccine efficacy. So we need to move more quickly than we're moving right now in terms of both suppressing transmission and in distributing the benefits of vaccines everywhere.
Thanks. I also want to come in on this because I do want to highlight two things. One is just the remarkable achievement that we've reached where we actually have so many safe and effective vaccines. I think we now take this for granted that we have these vaccines that are just available, and some are fortunate to be able to receive their doses. And that is because of decades worth of collaboration and investment in different platforms through the R&D blueprint for epidemics, the work on MERS, the work on SARS, really has advanced our ability to create these vaccines, safe and effective vaccines so quickly. But it does show the vulnerability that we have in this. But I have to come in on the public health and social measures. We have an amazing tool in vaccines and vaccinations, but we also have amazing tools in terms of individual level measures, in terms of societal level measures that can be tailored, that can be adjusted, that can be used intelligently. I'm not talking about lockdown. I'm talking about the use of a mask. I'm talking about physical distancing. I'm talking about improving ventilation. I'm talking about avoiding crowded spaces, making our workplaces safer, knowing what our risk is every day and taking measures to lower that risk. That has to receive the same amount of attention right now as vaccines and vaccination. And I will sit up here and be a broken record and continue to do so because we have tools that save lives right now. And unfortunately, we don't yet have the vaccines in the right places to protect people's lives. These vaccines are against severe disease and death, and they are highly effective against severe disease and death. That's what they are intended for, and that's what they need to be used for. This is what COVAX and WHO and all of our partners are advocating for, that these vaccines reach those who are most at risk for severe disease and who are most at risk because of their exposure, because they're caring for people who are sick, our frontline workers. So again, this is about the do it all in the sense that use the tools that we have. Governments need to support people in being able to do so because it's easy to say, do it, but we need to be supported in carrying out these measures because the decisions that we make today impact ourselves, impact our families, and they have consequences, good and bad. So let's continue to make good choices that we can, that we're in control of, and we need the good leadership to be able to enable us to keep ourselves and our loved ones safe.
Thank you all. Next question, Gabriela Sotomayor, Progreso, Mexico. Gabriela.
Thank you. Thank you very much, Tarek, for taking my question. Mexico cases and deaths have dropped dramatically in the last 5 months. Since late December to date, the government of Mexico City and the Mexican Institute of Social Security have had the strategy that each person who tests positive for the virus is given a kit with ivermectin for the patient and their family. In Mexico, the most populous city in the country, a study was carried out with 200,000 people, and it indicates that the use of ivermectin reduced the need of hospitalization by 76%. So I spoke with some specialists, and they say that the drop in cases and deaths cannot be attributed to the vaccine because only 20% of the population has been vaccinated. So my question is, what are your comments on this? Are you analyzing what is happening in Mexico in relation with the use of our ivermectin?
So thanks. So I could perhaps start, and others may want to come in because, Gabriela, thanks very much for your question. It's likely a combination of factors of why you're seeing transmission being reduced across Mexico. And it is indeed a very good sign that transmission is reducing and the cases are declining. And they've been declining over the past several months. I'm looking at the epi curve in front of me. And so it's probably a combination of factors that are associated with that, individual level measures that I just mentioned, as well as others. With regards to ivermectin, our recommendation is for the use of ivermectin in clinical trials. Our clinical management team, led by Dr. Janet Diaz, and collaborators around the world are constantly looking at all of the studies that are evaluating ivermectin. There are meta-analyses that are being conducted that are adding more studies as those studies' results become available, and as they are being updated regularly. And then once that meta-analysis is updated, then they will look at the recommendations again and decide if any recommendations need to be changed. That's a process that we have for all of the therapeutics that are being evaluated out there. It's the consolidation of evidence from all of the different small and large trials, putting together in a meta-analysis, conducting a robust, transparent, comprehensive review, and then looking at the recommendations to see what our guideline development group can and cannot, should and should not recommend. So that process is underway, and that will be updated soon.
So I think you raise an important point, because when you look at at a question about why cases and deaths may have reduced in a particular environment, as Maria mentioned, it's usually a combination of things. It's never the one intervention. So the vaccines, yes, the vaccines are protecting at first the high-risk groups, so the elderly and the frontline workers and the health workers, and that certainly has an impact on protecting the group that's been vaccinated, in which the deaths are likely to be the highest. So we know that the deaths proportionally are higher among the elderly. So if you've got that group covered, your deaths are going to come down, though infections may continue. Then you've got all the public health measures that one puts in place. And we've noticed in country after country that's had a peak and that's been able to bring it down, they've done it through a good, comprehensive set of public health interventions without ivermectin necessarily. And this, we can name a large number of countries where exactly the same has happened. So this is why, just an ecological observation, early on last year, we saw similar associations being made with BCG vaccination, with hydroxychloroquine, without taking into consideration the other factors. So I think it's really important to undertake properly designed studies, and we must have an open mind, and the WHO certainly has an open mind to look at each and every intervention that could be beneficial. So there are trials going on looking at BCG to see if BCG can reduce deaths or prevent infections due to COVID, due to its non-specific effect on the innate immune system. We had a number of trials that looked at hydroxychloroquine as well as at other antiviral drugs. And there are, unfortunately, not very high-quality trials yet conducted on the role of ivermectin, either in prevention or in the treatment of disease. And this is what our guideline development group pointed out when they looked at the meta-analyses, that the studies were all of very poor or low quality. And therefore, what is needed is more evidence. So observational studies sometimes give you hints about something that could be happening, especially when you're looking at the population level where there are so many interventions going on. But what you then need are well-designed studies to prove those hypotheses. And so we encourage more research on any of these, and the jury is still out on this.
Many thanks, Dr. Swaminathan, Dr. Van Kerkhove. Now we will go to Health Policy Watch Africa, and we have Kerry Cullinan with us. Kerry, please unmute yourself and ask the question.
Thank you very much. There have been some alarming reports about the lack of, or the failure of Sinovac to prevent health workers from being hospitalized in Indonesia. And it seems like it has very limited efficacy against the Delta variant in particular. Could the WHO comment on this, and also what would be your advice to countries that are using Sinovac only? Thank you.
So I'm not aware of this particular incidents that you are mentioning, but I think you're bringing up an important issue, and that was also mentioned by Mike just now. The whole situation is so dynamic because of the variants that are now circulating, and as you said, the Delta variant is well on its way to becoming the dominant variant globally because of its significantly increased transmissibility. We need more data, again, from well-designed studies on the efficacy of the different vaccines that are in use in different countries against the different variants. So what this means is that there has to be in place a study that uses a good design. It could be a randomized trial, or if not, it could be during the rollout of a vaccine in a country. We have designs like a test negative design, for example, and others that the WHO has actually compiled and provided on its website, different study designs that can be used to see what happens when people have 1 dose of the vaccine, 2 doses of the vaccine, how many are getting infected, and of those infected, how many are ending up hospitalized and getting seriously ill. And that kind of documentation will tell us, because again, anecdotally, one might see number of infections happening for whatever reason. If there's a lot of community transmission, there will be more infection among health workers. But are they getting ill? Are they needing to be hospitalized? And what's the proportion between the vaccinated, unvaccinated, and those with a single dose and complete dose? So this is something that we are watching very carefully and documenting, and we now have a special expert group that's been set up to exactly track the performance of vaccines and their effectiveness when used at the population level in relation to the variants. And so this also means that countries need to do sequencing. Side by side with documenting vaccine effectiveness, we need to expand sequencing, and maybe Maria can say more about how we're supporting countries to do that. And when we have both pieces of information, then we can start getting some solid and robust evidence on vaccine performance.
And just in general on Indonesia, there has been quite a steep surge in cases over the last few weeks. And again, as Sumi referred to before, in other countries, this is multifactorial. The number of cases has been on the rise after the end of the traditional holiday season, where millions of people move around in the Indonesian archipelago. There's a lot of travel. People move. We saw a similar phenomenon in Europe with the social mixing over the holiday periods. We think we saw similar issues in India. People move and mix. The virus goes with them, and you can get that buildup of infection. That has brought the healthcare system under some strong demand for healthcare services, and certainly in Jakarta, the hospital occupancy rates have increased to 75%, and the weekly incidence rate is up by 50%. Positivity rate is around 12–13%, which is quite high. It's not dramatically high, but there's no question that the intensity of community transmission has increased across Indonesia, particularly around Jakarta and also central Java and Kudus. And within that, the Delta variant is now becoming more prominent or more dominant in certain parts of Jakarta and other parts of Java. And that is a concern, given what we've learned about the ability of the Delta variant to transmit in other areas. So there is no question that Indonesia is facing increased community transmission, increased prominence of the Delta variant, and increasing pressure on the health system, though at the moment the health hospital system appears to be coping in terms of bed occupancy and strain on the system. But we've seen in other countries how quickly that situation can change. Once a peak occupancy is reached, once health systems begin to fail, they tend to fail quite catastrophically and rather quickly.
Dr. Aylward, would you like to add something?
Yeah, I just want to reinforce the importance of the point that Sonia made. Kari, when you asked the question about the alarming, you said the alarming reports of the failure of Sinovac in Indonesia. I think we want to be very clear that there are reports of people who receive Sinovac actually got the disease, the healthcare workers, but that does not mean failure of the vaccine, because as you know, vaccines are not going to protect everybody who receives them. And the Sinovac vaccine, the efficacy estimate is between 50 and 76%, or in that range, as you know. So it's not unexpected in areas where everyone gets a vaccine, as we get intense transmission, there will be some cases in people who are vaccinated, but very early to say whether or not a vaccine is performing the way it should. In fact, most indications are that the rate of hospitalizations among healthcare workers overall has gone down. And even though a number of healthcare workers in this particular area had the disease, very few of them, or actually it was only a smaller proportion who were hospitalized. But a super important event, an event that needs to be fully investigated. But I think we want to be very careful about suggesting there's evidence that a vaccine is failing, because there certainly isn't the evidence to suggest that at this point.
Many thanks, Dr. Aylward. So let's go to Agence France-Presse, Christopher Wacht. Christopher?
Yes, thank you for taking my question. I just wanted to come back on what Dr. Tedros said about production, and especially production in Africa. You were pointing to some news on Monday, but I was wondering if you could maybe tell us a little bit more in advance on that. We have been waiting for quite a while on the different schemes that you were trying, or not just you, but also WTO, to put into place to have more production, especially regional production in Africa. So I was just wondering if you could tell us a little bit more.
Yeah, thank you very much. We're working with some countries who are making concrete steps, and I would appreciate it if you can, have the patience, and it will also be probably a surprise for you on Monday. I would, prefer to keep it for Monday, and then you will have all the information from an African country that's taking concrete steps, as I said earlier. And also, hopefully, we will bring a northern partner also. This is a north-south partnership. And hope you will get everything from the horse's mouth from them. Thank you.
Thank you, Dr. Tedros. I think next question is also about Africa. We have it as Georgi Al-Hadji from Premier Continent. Georgi, you have the floor. Hello, Georgi, can you hear us?
Allô?
Oui.
Oui, vous m'entendez?
Oui, très bien. Tu peux y aller.
Ah bon, d'accord. Gorgui Ndoye pour le Soleil de Dakar et Continent Premier. J'avais une question à l'attention du directeur général, M. Tedros. Ces derniers jours, vos services en Afrique, notamment à Brazzaville, ont annoncé qu'il y a une résurgence des cas en Afrique et qu'aujourd'hui, nous serions entrés dans une troisième phase. Comment vous expliquez-vous cela? Est-ce que les pays africains qui jusqu'à présent étaient moins touchés se sont relâchés? Ça, c'est la première question par rapport à ça. La deuxième, c'est par rapport aussi aux vaccins. On voit qu'effectivement, beaucoup de pays sont en train de consommer les vaccins qu'ils reçoivent, mais si on arrête, par exemple, avec la question de l'AstraZeneca, est-ce que la confiance va revenir? Je vous remercie.
Yeah, thanks very much. I'll start, and I'm sure others will want to come in on this. So let me first start with the first part of your question around the situation in Africa. And Africa is a very diverse continent with many countries and many populations. And so we don't want to overgeneralize an entire continent, a situation on an entire continent. But there certainly are a number of countries across Africa that are seeing alarming increases in cases. In part of your question, you said that Africa was largely spared in the beginning, but indeed many countries across the continent have had severe outbreaks, have brought outbreaks under control through this combination of factors, this comprehensive strategy. Seroprevalence studies across the continent have actually shown us that a proportion of the population has been infected. Seroprevalence rates of between 10, 20, 30%. Indicating that there is unrecognized cases that have occurred on the continent. And part of that is due to the lack of testing in many countries. And we are working with many ministries and with our regional office, with our country offices to improve testing capacity across the continent, in particular the use of PCR tests, the use of antigen-based tests, which can be conducted outside of labs in clinical settings by trained individuals and into communities to really know where the virus is and to carry out appropriate public health measures. But there are a number of increases in countries right now, seeing a third peak or a third wave, as you put it. And a number of countries are reaching or passing their capacities for ICU. They are reaching or passing their capacities for O2 that they have right now, and the supplies to be able to use medical oxygen for patients who so critically need it. In a number of countries, we're seeing the test positivity rate exceeding 10, 20, 30%. And so we know that there are situations where cases are increasing. We also have variants of concern that are circulating in many parts of Africa. Our ability to know where these variants of concern are circulating is limited by our ability to conduct genetic sequencing, and we're working with our African Regional Office and Africa CDC to boost sequencing capacity across the entire region so that we know where these variants are circulating. But indeed, it is a worrying situation. And remember, in parts of Africa, we're in our winter months. And in our colleagues from our regional office say, we're reminding us that in some countries there's snow on the ground, and so people are spending more time indoors as opposed to outdoors. And we need to ensure when that happens, we have good ventilation indoors, that masks are worn, that masks are provided, that they are worn appropriately over the nose and the mouth, they have the right filtration, that our hands are clean so that when we put on and we take off that mask, that we're not inadvertently infecting ourselves, that we clean our hands. We use all of those measures. But 18 months into a pandemic, it's incredibly difficult to sustain these measures. And this is why vaccination and vaccines reaching those most at risk, particularly across the continent, is critical. And it's now that we need these because people are dying now. So we are working through our regional offices and our country offices to provide the best support that we can, and providing the supplies, ensuring that our health workers are protected, are cared for, are operating in safe working environments, that oxygen and the related supplies, medical oxygen and the related supplies are reaching those most in need, that the dexamethasone is reaching those who are most in need, used for the right patients who are severe and critical at the right doses and for the right amount of time. So it's a combination of factors that are necessary to be able to support countries that are indeed seeing some quite worrying signs of increasing transmission.
Yeah, and may I just add that it's when you look, and any of you can look on our website and see the numbers. When you see the absolute numbers, it doesn't appear that our African region is in necessarily bad shape. It's only in the last week represents just over 5% of global cases and over 2.2% of global deaths. But given what Maria said about underdiagnosis on the continent, it's trajectory that's very, very concerning. And in the last week, we've seen over 100% increases in Namibia and Sierra Leone and Liberia, in Rwanda and Zambia and Zimbabwe and Malawi and Lesotho, in Congo and South Sudan. We've seen between 50 and 100% increase in cases in places like Mozambique, in Cote d'Ivoire. So this phenomenon, and in South Africa and in Uganda and in many of these countries. So this is a phenomenon occurring across the continent. As Maria said, the factors driving it may be seasonal in the southern Africa. There may be other factors driving it elsewhere. But the brutal reality is that in an era of multiple variants, with increased transmissibility, potentially increased impact, we have left vast swathes of the population and the vulnerable population in Africa unprotected by vaccines, in a context where health systems are already weak. That's the reality. And this is the consequence of the current unfair distribution of vaccines. If we had been distributing vaccines fairly and equitably, we may by now have protected those people most vulnerable on the African continent, and we simply have not done that. And whatever the factors that are driving this, be it exhaustion in the system, be it the fact that people have to go back to work, be it seasonal, the reality is that the population that needs to be protected is not. And we have the same concerns in African countries in refugee situations at the moment. We've seen before the presumption that the next wave will be the same as the previous wave. I think every country has learned that every wave is unique, because it depends on the season, it depends on the health system, it depends on the variant, it depends on the intensity of transmission. So how the virus epidemic manifests itself on each wave has been different in every country. So to assume that the next wave in Africa is just going to be a small passing shower and will not be a storm, I think is very, very premature. And I think we have to really take what's happening on the African continent very, very seriously. Our African Regional Office, led by Chidi Moeti, Dr. Tedros, and others, have constantly spoken about this inequity. And we're going to pay a heavy price for that inequity in the coming weeks and months. We hope not. I dearly hope that is not the case. But the trajectory and the direction of travel and the point of impact of this pandemic is switching around the world. I've said that before. And it is very clear that there are strong signals coming from Africa and from the African region of WHO that the disease is on the rise, the impact is rising, and we need to move quickly to support those systems and get the most vulnerable people vaccinated in Africa.
Thank you very much. I see that Dr. Aylward would like to add something to this question. Dr. Aylward.
Thank you very much, Tarek. It was on the specific question that was asked about one specific vaccine you asked about in the Africa context. And of course, there's often questions and hesitancy about vaccines in general or classes of vaccine and sometimes specific vaccines. And that's the reason that there's 2 or 3 key things that are being done to try and address that with the rollout of the vaccines, because all of the vaccines that we recommend that WHO has given emergency use listing to, we've looked at very carefully and can speak to their safety, efficacy, quality assurance, and their programmatic utility. So the key things we're trying to do is get the accurate information out there so that people are making evidence and accurate-based personal decisions as well as population level decisions. The second thing that we're working toward is ensure that they're getting the information from the right channels through leaders, local leaders, other leaders, religious leaders that they know and they respect and they trust to provide that information. And of course, this comes back to the role of the press, which is just so important in helping ensure there is accurate information about these vaccines, because all of these products, the benefits far exceed the risks given the gravity of this disease and the waves of disease that we're seeing. And we're going to need a concentrated approach to help ensure people understand those realities and get themselves protected as rapidly and quickly as possible. But to the point Mike makes, and that Dr. Tedros has spoken to again and again, the big problem now is not hesitancy anywhere in Africa, many of the places we serve through COVAX, it's lack of vaccine. You can't hesitate to take something that's not available. Let's get the vaccines out there, get them available to people to help get the coverage rates up. That's the crucial thing at this point.
Thank you very much, Dr. Aylward. And with this, we will conclude this press briefing. As always, we will send the audio file later in the evening, and transcript will be posted at our website tomorrow. With this, I wish you a nice weekend, and I give the floor to Dr. Tedros for his closing remarks.
Yeah, thank you, Tariq, and thank you to all who have joined today, and see you in our upcoming presser. Thank you. Bye-bye.